Welcome to Electrolyte Imbalances. This is really looking at sodium, potassium, calcium, phosphate, magnesium, really important electrolytes to your body and what the highs and the lows can do to them. It is highly recommended that you look at your study guides and you work through them. A lot of this is empty space to think and put things in boxes, but comparing high sodium to low sodium, comparing high potassium to low potassium in a way that's visually easier for you to study. So I highly recommend look at this, read the chapter, and then really use that study guide to put down your thoughts to make it easier to study for your exams. So the first thing when you're really looking at all these electrolytes, you want to know and memorize the normals. That is the first thing you should do. Sodium balances typically associate with parallel changes in osmolality. Usually, sodium is lost through sweat, urine, and feces are the top three things we think about. But kidneys are the major regulator of sodium. So sometimes if something's wrong with the kidneys, something's wrong with your sodium levels. Sodium plays a major role in ECF volume and concentration, generation of transmission of nerve impulses, and muscle contractility. Causes of hypernatremia, which is usually sodium levels greater than 145. I love this. Loads, so low water intake. Osmotic diuretics, such as mannitol, which is usually given to decrease intracranial pressure. Diabetes insipidus, excessive water loss. And sodium intake too high from either medications or meals. Excess sodium, usually lab findings, you will find obviously high sodium levels, but also high serum osmolality and high urine osmolality. So again, think kidneys, urine, but your specific gravity is a level that you definitely want to be looking at and memorizing. You usually feel fried from too much sodium, flushed, maybe a fever, low grade, restless, irritable, progressing to confusion and seizure, increased fluid retention, edema, excitable muscles, maybe some irritability, some twitching, exhausted muscles is another one, and then decreased urine output, maybe dry mouth, increased thirst. I like this except for in the elderly people. Sometimes you will not see the increased thirst. Sodium excess, usually our nursing interventions, we want to decrease sodium intake. Now there's quite a few foods that cause high sodium. Fried fast foods, takeout, soda, smoked meats such as hot dog and bacon, canned food, frozen dinners, salted snacks, basically any college student's dream life right there. We can promote oral hygiene because usually they have dry mouth. We can use diuretics such as Lasix that inhibits sodium, potassium, and chloride reabsorption. Increase water intake, use hypotonic or isotonic solutions, and monitor for adequate eyes and nose. Usually you don't want to drop their sodium levels quickly, so you want to be very careful and slowly drop sodium levels. Otherwise you can get some confusion and some other things that we don't like. So think changes in sodium, you want to change it back down slowly. Hyponatremia results from loss of sodium containing fluids and or excess water loss. Usually common causes, you could have lots of diaphoresis, draining wounds, trauma from significant blood loss, excessive diarrhea or vomiting. You can sometimes give patients too much water, aka after surgery or major trauma. They come in, we pour fluids in these people, maybe they have renal failure already and we gave them a couple units, and so that causes some hyponatremia. There's also some people that have psychotic disorders where they have excess water intake. We've had times where we've had to shut off water in patients' rooms because they are so desperate for water, but it keeps dropping their sodium levels. Clinical manifestations, you can see confusion, irritability, headache, can progress to vomiting, seizures, or coma. Usually they first manifest in the CNS, so Usually the cellular swelling are first manifested, and you'll see like confusion, and it's usually due to cerebral edema. Decreased lab values. So you'll see decreased sodium levels, decreased serum osmolality, and decreased specific gravity. Clinical manifestations, you'll see decreased muscle strength, decreased deep muscle reflexes, increased confusion, increased lethargy, dizziness, usually leading to seizures, and then symptoms of hypovolemia versus maybe hypervolemia. You could see increased pulse or decreased blood pressure and a bounding pulse sometimes. Interventions. Think sodium. We are going to look at sodium intake and seizure precautions is a big one. Sometimes to high in sodium diet like broth, tomato juice, canned vegetables, things like that. Overload, we're going to restrict water intake. And like we said with some of those psych people or different things, they are thirsty, they want more fluid, but we have to restrict their water intake. Daily weights, intake and output. Use isotonic fluid because we're restoring the ECF. And then monitor postural hypotension. You'll see an increased heart rate, decreased blood pressure, dry mucous membranes, and LOC. Just like with hypernatremia, you do not want to replace too quickly. The brain cannot handle those sudden changes. So if symptoms are severe enough and they're having all these kind of symptoms, we might give them 3% normal saline. This is very, I would count it as a very dangerous solution that we want to use correctly. Patients usually are in the ICU, they're given slowly in small amounts until they can switch back to normal saline. Potassium, so we're switching from sodium to potassium. It's a major ICF-cation, necessary for transmission and conduction of nerve and muscle impulses and maintenance of cardiac rhythms. When I think potassium, I think also heart, okay? You really want to be careful of cardiac function when it comes to potassium. Imbalances can cause patients to not do well, go into different cardiac rhythms. So when you are doing your comparative, really look at those cardiac rhythms and what they will look like. Sources of potassium: fruits and vegetables, salt substitutes, potassium medications, blood transfusions, and again, this is usually regulated by the kidneys. Causes of hyperkalemia: impaired renal excretion, aka their kidneys are not working, shifts from ICF to ECF, and massive intake. That's pretty less likely. It would take a lot of like high potassium level foods to cause this, but you do not see that normally. This is most common seen in renal failure. Manifestations of hyperkalemia: usually restlessness, neuromuscular, weak or paralyzed skeletal muscles, bilateral muscle twitching, leg pain, cramps initially as levels increase. Could progress to paralysis or paralysis of respiratory muscles, which is dangerous. GI, you'll have abdominal cramping or explosive diarrhea due to hyperactive of the smooth muscles, aka your body's trying to get rid of that excess potassium. You'll hear hyperactive bowel sounds. Vital signs, you'll see low irregular P wave or in hypotension. Cardiac muscle, very sensitive to potassium imbalances, so you'll see dysrhythmias such as PVCs, VFibs, peaked or tinted T waves, and wide QRS. So as you can see here, these are some very high P waves. Those are some of the ones that people automatically notice really a lot of times with EKG changes of potassium. Nursing implementation, severe, we're monitoring their cardiac rhythm. We want them on telly, we want to see what they're doing. Usually we'll administer things like calcium gluconate, which is given IV, so we're watching their blood pressure. If they are already a dialysis patient, maybe we are going to give them dialysis, but sometimes we need to give them emerging dialysis anyway. Moderate, we're going to force potassium from the ECF to the ICF by IV regular insulin. So yes, they are not diabetic all the time. We are still going to give them insulin, and we're going to give them glucose to counteract that. And that's going to help potassium move from the ECF to the ICF. And then mild, we're going to ask them to stop intake of potassium. We might change up their medications and their food and their diet. If they have no kidney dysfunction, maybe we'll give Lasix to promote potassium excretion. And then the other one is give Electrolyte to promote potassium excretion. It's going to have them have that explosive diarrhea that we saw in their manifestations, which is going to rapidly get rid of their potassium levels. It's not always very fun for the patients or sometimes the nurse, but it does rapidly get rid of that potassium. So this shows what a tele monitoring look like. We're really watching their tele, and if I can't push anything it's enough, it's that potassium levels really do affect the heart so much. So you want that tele in the cardiac monitoring. All right, switching to hypokalemia, usually caused by GI losses such as vomiting, NG suctioning, diarrhea, and laxative use. Renal losses, you'll see diuretics such as Lasix, use of corticosteroids, and digoxin. Skin losses, diaphoresis and wounds. Insufficient potassium, maybe dietary changes or prolonged non-electrolyte IV solutions, so a patient that's gotten D5W for a long period of time. And then intracellular shifts. Tissue repair such as burns, starvation, and trauma can cause that shift of potassium. Older adults have higher risk of hypokalemia because of laxative and diuretic uses. Labs, we're going to look at the serum potassium and ABGs. We'll talk about metabolic alkalosis later, but in the next section, but know that that is a cause. Manifestations, vital signs, we're going to see a decrease in blood pressure and orthostatic BP, weak or regular pulses. Neuro, we're going to see altered mental status, lethargy, coma. We're going to see flat T waves. And then hypoactive bowel sounds due to decreased GI motility. Body's trying to keep that potassium and absorbing it, which can cause some nausea and vomiting. You might see weakness. Usually it starts in the legs and moves up, so it can cause paralysis. When it moves up, that's when we see weak respiratory muscles, such as shallow breathing, which can cause respiratory arrest. The other cardiac issue that it can really cause is VTAC. So we're going to watch out for ventricular tachycardia. So again, we're thinking heart, and we're thinking I need to watch their cardiac monitor. So this shows EKG changes with potassium. This is a really good way to see the difference of normal versus hypokalemia and hyperkalemia. Nursing implementations. So we're going to give potassium supplements orally or IV. Always dilute IV potassium. Always give IV potassium slowly, and always think, I do not want to bolus potassium. This can cause dangerous cardiac arrhythmias that can kill somebody. Maximum concentration we usually give is 40 milliequivalents. We can see up to 80, but usually we do 40 and then check their potassium levels to see how they're doing. You really want this on a pump, and be very careful about the administration rate to make sure we're not bolusing it. And because it's irritating to the vein, we really are watching for phlebitis and infiltration because it can really cause issues. Nursing interventions, think potassium. We're going to have them eat different kind of potassium-rich foods such as potatoes, avocados, broccoli. Oral potassium supplements. We're going to watch for the T-wave depression and for arrhythmias. We're also going to watch for shallow, ineffective respirations and sounds of breathing, their breathing diminishing. We're going to give IV supplements, again, never IV push. And then urine output. We're going to monitor closely, and muscle cramping and motility in their GI. We're going to watch those things. Calcium. Their functions of calcium: transmission of nerve impulses, muscle contractions. You think muscle contractions a lot when you think calcium. Myocardial contractions, formation of teeth and bone, and blood clotting. Calcium is usually obtained from ingesting foods, but you need vitamin D to absorb. Usually calcium balance is controlled by the parathyroid hormone, or the PTH, and calcitonin. Um, Really, you want to look at, is there an issue with the PTH? Usually increases bone reabsorption, increases GI absorption of calcium, increases renal tubule reabsorptions of calcium, where calcium or calcitonin is produced by the thyroid gland, and it still stimulates an increase in serum calcium levels, opposes the act of PTH, and decreases GI absorption of calcium deposits in the bone. Hypercalcemia. Usually hyperparathyroidism is about 2/3 of the case of this. Usually it's prolonged immobilization results in bone mineral loss. And a lot of times what I think of when I think of hypercalcemia, I think of malignancy, aka they've got some kind of cancer that is eating through the bone, which is putting through more calcium into the body. Manifestations, usually you see lethargy, weakness, stupor and coma, depressed reflexes, muscle contractility issues, confusion, personality changes, psychosis, anorexia, nausea, vomiting, bone pain, fractures, and polyuria, dehydration, and risk of renal calculi, aka kidney stones. Nursing implementations for hypercalcemia. You see excretion of calcium with loop diuretics, hydration with isotonic saline infusions, low calcium diet, mobilization, synthetic calcitonin, and bisphosphonates. Hypocalcemia, serum calcium levels caused by decreased production of PTH, usually after thyroid and neck surgeries, acute pancreatitis, multiple blood transfusions, alkalosis, and increased calcium loss. You'll see a positive Trocher's or Trovex signs. Laryngeal stridor is a big manifestation that some people don't think of, but it's usually due to hypocalcemia. Tingling around the mouth or in the extremities, and cardiac dysrhythmias. Really, those cardiac dysrhythmias, you can see a prolonged QT interval, which may develop into ventricular tachycardia. So this shows the different signs and how you will assess for them. A lot of people, when they think of the Trocher sign, it's like, oh, I took my patient's blood pressure and all of a sudden they kind of had this hand movement with it. But that's what we're really looking for. If you see that, you're thinking it's a sign of low calcium. Nursing implementations, we're going to treat the underlying cause. Usually that's the primary goal. Oral or IV calcium supplements, not IM, to avoid local reactions. Sometimes the supplements could include things like Tums even. Usually we're having them have diet high in calcium-rich foods, along with vitamin D supplementations, because that's what's going to help the body absorb. Sometimes we can have them rebreathe into a paper bag. That can help with the treatment of hyperventilation-induced respiratory alkalosis, which causes the hypocalcemic symptoms. And then treat pain anxiety so we don't have that hyperventilation. Phosphate, a primary anion in ICF, essential to the function of muscles, RBCs, and nervous system, involved in acid-base buffering systems, ATP production, cellular uptake of glucose, and metabolism of carbs, proteins, and fats. Serum levels controlled by parathyroid hormone, so the PTH. Maintenance of phosphate requires adequate renal functioning, and reciprocal inverse. So this is something that's important, is how phosphate and calcium react with each other. So if you have high phosphate, usually you have low calcium. If you have low phosphate, you usually have high calcium. So you might see a question somewhere that's like, hey, this patient's phosphate's abnormal. What is their calcium going to look like? Hyperphosphatemia, usually caused by acute kidney injury, chronic kidney disease, chemotherapy, and excess ingestion of phosphate or vitamin D. Manifestations, usually neuromuscular irritability and tetany. That is due to the hypocalcemia. Think of the reverse. Calcified deposits in soft tissue such as joints, arteries, skin, kidneys, and corneas. So this can cause further organ dysfunction of other areas. So management, we're going to identify and treat underlying causes. We're going to restrict food and fluids containing phosphorus, sadly, usually dairy such as milk and yogurt. We're going to have them take phosphate binding agents, maybe some Tums, as well as adequate hydration and correction of hypocalcemia conditions. And they might need hemodialysis, IV insulin, and glucose if severe hypercalcemia. Hypophosphatemia. Rare but low sodium phosphates can be caused by malnourishment, malabsorption, alcohol withdrawal is a big one, use of phosphate binding antacids such as Tums, and during parental nutrition with inadequate phosphorus replacement. Manifestations, usually mild or moderate, is often asymptomatic. So we don't usually see this until it's severe, which may become fatal quickly. Once we see the symptoms, such as CNS depression, confusion, and other mental changes, muscle weakness and pain, dysrhythmias, and cardiomyopathy. Management, usually oral supplementation, ingestions of food with high phosphorus, which is usually dairy, IV administration of sodium or potassium phosphate requires frequent monitoring of lab values. Usually, sudden symptomatic hypocalcemia secondary to high calcium phosphate binding is a potential complication of IV phosphorus administration. Magnesium, usually coenzyme in metabolism of protein and carbohydrates. It's required for nucleic acid and protein synthesis. It helps maintain calcium and potassium balance and necessary for sodium and potassium pump. So magnesium is one we look a lot when we're looking at potassium issues because they're so interrelated. So you want to make sure that somebody's magnesium level is correct. Magnesium acts directly on myoneural junctions. It's important for normal cardiac functions, and 50 to 60% is contained in the bone, actually. It's also absorbed in GI tract and excreted by the kidneys. Usually hypermagnesemia is an increased intake or ingestion of products containing magnesium. Usually only creates a problem when renal insufficiency and failure is present. AKA if somebody eats a lot or drinks a lot of magnesium, it's usually not symptomatic until there is kidney issues. Excess IV magnesium administration, though, can cause it. Usually see this in pregnant women who are receiving IV magnesium for management of eclampsia. Manifestations, you'll see lethargy, nausea and vomiting. It's usually the signs and symptoms while it's mild. As the levels increase, you'll see impaired reflexes, somnolence, and eventually respiratory and cardiac arrest. Management of hypermagnesemia, we're prevention first, so we're not going to have them eat or intake anything that has magnesium in it. Emergency treatment, we can give IV calcium chloride or calcium gluconate to oppose the effects of magnesium on the cardiac muscle. Oral and parenteral fluids and IV furosemide to promote urinary excretion of that magnesium. And sometimes dialysis is required if they have impaired renal function. Low magnesium, usually caused by prolonged fasting or starvation, chronic alcoholism. This is the most common cause, and it's something that a lot of nurses see with alcohol withdrawal patients and different patients with high uses of that alcohol. Fluid loss from GI tract, prolonged parental nutrition with magnesium supplementation, without magnesium supplementation, diuretics, which cause renal excretion of magnesium, and hyperglycemia, osmotic diuresis, and uncontrolled diabetes. Manifestations, you usually see confusion, hyperactive deep tendon reflexes, muscle cramps, tremors, seizures, cardiac dysrhythmias such as PVCs or VFib, and corresponding hypocalcemia or hypokalemia. Management, our primary goal is to treat the underlying cause. Oral supplements, decrease dietary intake of magnesium, and then parenteral IV or IV magnesium whenever it's severe enough.